Hello, my name is Dr. Pradeep Pallati, General Bariatric Surgeon, CHI Health, Allegiant Creighton University Medical Center. Today I will be presenting a webinar regarding all you need to know about weight loss surgery. A short note about myself. I did my medical school back in India, followed by a 3-year surgical residency. Then came to United States in 2006, and I came directly to Omaha. I did my surgery training at Creighton University Medical Center for 5 years, followed by a minimally invasive laparoscopic and bariatric surgery fellowship in University of Nebraska Medical Center. Since then, I've been employed with Allegiant Creighton Health, Creighton University Medical Center for the past 2 years, and been doing bariatric surgery and minimally invasive surgery. The objectives of the seminar today would be: first, what is obesity, why you should consider losing weight, then how you can lose weight, then why weight loss surgery, what are the various weight loss surgeries, what to expect after surgery, and also touch small base with frequently asked questions. What is obesity? Obesity is calculated based on the body mass index, the BMI. If you are between 18.5 to 24.9, that's normal weight. Anything more than 25 BMI is overweight. Above 30 is obesity class 1. Above 35, class 2 obesity. And more than 40 is class 3 obesity, or what we call morbid obesity. As you can see, the disease risk gets higher and higher as you get more obese. This obesity trends among the US adults, as you can see, we were not obese in the past. This obesity has become a pandemic recently, growing from 1985. As you can see, the incidence of obesity was less than 10% in many states, followed by light blue and dark blue. 5 years, 1990, followed by 1995, 2000, they become more and more yellow, increasing 20-24% obesity, becomes 2005, and by 2010, you can see there are many states which have more than 30% obesity within their state. So what is the scope of the problem today? More than 50% rise in obesity over past decade. Nearly 2/3 Americans, or 130 million people, are overweight and obese, and over 11.5 million Americans are morbidly obese, which means the BMI is more than 40. The estimated $238 billion healthcare dollars are spent to treat and manage obesity. And obesity has replaced smoking as America's #1 preventable health problem. Obesity is not confined to America only. You can see in Egypt, more than 59.1% are overweight or obese. Mexico, more than almost 70% are obese. In China, more than 27% are obese. So it's a growing problem all across the world. It's not limited to just United States. What are the causes of obesity? There are multiple. It's a multifactorial causes. Genetics, you can see that 90% chance of morbid obesity if both parents are morbidly obese. There's decreasing energy. The resting energy expenditure is less, and the response to calories is also less. Diet, excess calories, excess fat, limited activity due to advancement in technologies. Medical therapy, some of the medications that we use, including diabetes medications, hypertensive medications, can result in obesity. And psychological factors with stress management, eating habits. So there's a multifactorial cause for obesity. Okay, next, why you should consider losing weight. It's only one slide here, but it speaks completely. Increased risk of dying prematurely, roughly 4 times higher than normal weight controls. For Caucasians, loss of 13 years, and for the African American population, loss of 20 years of life. Cardiovascular death is increased 50% for obese and 94% for class 3 morbidly obese. How you can lose weight? Medical treatment. For class 3 obesity and greater, the medical treatment is indicated. Diet is long-term success, however, is low, less than 5%. Exercise is part of a lifestyle change. You need to do that. Medications, including Xenical, Meridia, Qsymia, and other medications that are coming up. usually result in only 5 to 10% of excess weight loss. Weight regained once medications are stopped. As you can see in this major journal publication, all the different medications on the left have resulted only up to 3 to 5% of the excess weight loss. So it's not very effective in keeping the weight off and getting the weight off. So the same journal has mentioned that diet and physical therapy and behavioral therapy are indicated for all obesities. But as you become morbidly obese or class 3 obesity, surgery is getting to be indicated. So this report of WHO consultation on obesity in 1997 itself mentioned that surgery is now considered to be the most effective way of reducing weight and maintaining weight loss in severely obese and very severely obese subjects. On a kilo by weight loss basis, surgical treatment has been estimated after 4 years to be less expensive than any other treatment. So, now we come to why weight loss surgery. The impact of weight loss on patient survival, as you can see, it's because it saves lives. If you look at the 15-year mortality without surgery, all ages, it's around 16%. But if you have surgery, it goes down to 12%. And if you're under 40, the benefit is even more. If you have no surgery, the chance of dying in the next 15 years is around 14%. But surgery brings it down to around 3%. This is another study that was recently published in last year, which shows this graphical description of mortality or chance of dying. The green is the line for weight loss surgery, and the purple is the one with no surgery. As you get older and older, the chance of dying are more and more with no weight loss surgery. Next, bariatric surgery also saves money and hospitalizations. As you can see, for the next 5 years, even including the weight loss surgery itself, the number of hospitalizations is less than not undergoing surgery. Just because you are morbidly obese increases the risk of hospitalizations for other medical problems, including chest pain, pneumonia, blood clots. All this can increase the risk of hospitalizations. The hospital stay is also less. Physician visits are less. Total cost, including the surgery, is less by the end of 5 years. And also, you can see this slide mentions it all. The return on investment. You look at the surgery, there is a high initial investment, but over the course of next 4 to 5 years, this no surgery group has more and more money spent, and there is a return of investment within 3 to 4 years of time. Even the medications, number of medications used for diabetes control, you can look at this article in another renowned journal, which show that with medical therapy itself you still continue to take 3 to 4 medications for diabetes. But if you undergo surgery, the medications come down to 1 or less than 1, depending on what kind of surgery you have, either sleeve gastrectomy or gastric bypass. This is another slide which shows all the other comorbidities, including high blood pressure, hyperlipidemia, asthma, heart failure, sleep apnea, or majority of them are either cured or definitely improved after surgery. This is another chart which shows the impact of quality of life. Initially, the top graph you can see, that's the baseline, and after 3 years, the inside is without surgery and the periphery is with surgery. The more you're on the periphery, the better you are in general health-wise. And you can see that weight loss surgery improves your general quality of life. This is another sickness impact profile. If you are cirrhotic or Crohn's disease or myocardial infarction, you have, based on all the numbers, we calculate a sickness profile, and they're higher. You look at obesity, you're sick, 24% sickness. But after surgery, that sickness goes down to 6%. You're way better than other medical problems. Okay, then what are the various weight loss surgeries? People come to the seminar and looking for other weight loss surgeries. These are all the 4 weight loss surgeries that are popular at present. The first one on the top left is the laparoscopic adjustable gastric banding, where you put a band across the proximal stomach. Second on the top right is the sleeve gastrectomy. Third on the bottom left is the Roux-en-Y gastric bypass. And the fourth on the top bottom right is the biliary pancreatic diversion, also called BPD. What is the terminology of these weight loss surgeries? We talk about malabsorptive surgeries. The historic only, we used to do jejunal-ileal bypass, where you can eat whatever you want, but you had a lot of malabsorption, and it has caused significant problems, and hence it's not performed anymore. What then? Restrictive means basically these surgeries act by restricting how much you can eat. Gastroplasty, gastric banding, sleeve gastrectomy, and a combination of both restriction and malabsorption works with gastric bypass and biliopancreatic diversion. Let's talk about gastric banding. The adjustable gastric band is a silicone belt with an inflatable balloon in the lining that is buckled into a closed ring around the upper stomach. A reservoir port is placed under the skin for adjustments to the stoma size. These adjustments are done in the clinic, and you can based on this adjustment you can vary the size of the pouch, and it will decrease or increase the pouch size. It works by restricting the amount of food you can eat. What is the good and bad of this surgery? The benefits: it limits food intake, very few complications with surgery itself, less vitamin deficiencies, very infrequent protein malnutrition, and it's reversible. You take the band out and you're back to normal anatomy. What are the disadvantages? The weight loss is moderate. The other complications of the band itself, including slippage, rare erosion, and most often or not, the problem is the late weight gain. The long-term complications are the band slipping and migration. You can see those, all the complications that can happen with the band, around 9% of them. Next is sleeve gastrectomy. The technique consists of removal of 70% of stomach and creates a long and narrow tubular stomach reservoir with no intestinal bypass component. It works as if like a banana stomach. You can fill it up, but the lack of the excess stomach also makes your appetite go down, and you not only eat less, but also you feel full sooner, and you're not hungry as much after the sleeve gastrectomy. It was the first step in super morbidly obese patients, but then followed by either a bypass or a BPD. But now it's being used as primary procedure with some early results favoring its use. It may require second operation if weight loss is insufficient. And this surgery has been now for over 10 years or so, and we have fairly good results with this surgery itself. So what is the good and bad of this surgery? Like I said, it limits food intake, again, fewer complications than the next surgery, less vitamin deficiencies, less protein malnutrition, and the decrease in appetite that favors weight loss. What are the disadvantages or the complications that can happen? Rare dehiscence of the stomach, leaks, fistulas, ulcers, the long-term esophageal motility problems, and we don't know it. It's a new procedure, it's been there only for 10 years, and it's not reversible. You cannot put the stomach back. These are the long-term complications after sleeve. You can develop a stricture, bleeding, kidney failures, infections, around 5%. Next, we come to the most common procedure that has been performed in the United States, which is the gastric bypass procedure. Here, we divide the proximal stomach into a small pouch, around an ounce only, and divert a piece of small ball and hook it up to that small stomach pouch. It works by limiting the food intake and also by diverting that food directly into the small ball and not letting that food get digested by the digestive juices. So there is a component of restriction and also malabsorption in this case. So what are the good and bad of this surgery? This, as I said, it limits food intake again, has less complications compared to the next worst, biggest surgery, limited diarrhea, infrequent protein malnutrition, very good weight loss, satisfactory weight loss results, and it's reversible again. What are the disadvantages? Marginal ulcers, fistulas, development of gallstones, anemias, vitamin deficiencies, and very low late weight gain. These are the long-term complications. As you can see, this removal of the gallbladder, other surgeries that may need because of the bowel obstructions, hernias. Okay, the last surgery is the biliopancreatic diversion, which is not performed as commonly across the United States. It only amounts to around 1 to 2% of the weight loss surgeries that have been performed in the United States. What in this case is we do the same procedure. The first part is a sleeve gastrectomy. We remove a big portion of the stomach and make a banana-like stomach. And also we divert a majority of the small bowel and hook it up directly to this piece. As you can see in the lower part of the picture, we have only approximately 2 to 3 feet of bowel where the digestive juices meet the food and they have less chance to digest. So the malabsorption is more in this surgery compared to all other surgeries. So there is an element of restriction but also severe malabsorption on top of it. What are the good and the bad? It's the benefit compared to the gastric bypass, the pouch is bigger, so you're able to eat slightly large amount of food, less complications of the liver, diarrhea is still there, the weight loss is the best of all, and there's less late weight gain. What are the disadvantages? Stomal ulcerations, steatorrhea, which is a diarrhea of fat, and that results in the most commonest complaint from the patients, which is the foul smelling diarrhea. They have 3 to 4 bowel movements a day and it's very foul smelling. And the flatus, there are a lot of flatus. Gallbladder stones are common, but we do nowadays go ahead and take the gallbladder out at the same time of surgery, knowing that this is a potential future complication. There's significant protein malnourishment. People lose a lot of muscle in this surgery, and it's irreversible. Okay, so we talked about all the weight loss surgeries. Now we need to know what's the good about all this, comparison wise. You can see that the BMI change. Let's consider a BMI of 40 for just a comparison. If you do the band, you come down to BMI of 30. You have a good weight loss, but you still are obese. If you do a sleeve gastrectomy, you come down to BMI of 26. You are still overweight. If you consider gastric bypass, you come down to 23. And if you are doing a BPD, you come down to a BMI of 22, which is of normal weight. If you look at diabetes, over the progression wise, BPD is the best to cure diabetes, next the bypass, followed by sleeve and band. Similarly, high blood pressure and sleep apnea, they are pretty much the same. Okay, what can go wrong? What are the complications? What are the chance of dying from this surgery? Mortality is the least with the band surgery, but is the most with the BPD. It takes longer to do the surgery, it has multiple connections, it has higher risk, the BPD. Bypass is reasonably safer, 0.2%. If you look at morbidity, the complications that can happen, it's around 1.5 to 9% in band, sleeve 6 to 9%, gastric bypass 4 to 8%. BPD has the highest chance of complications. This is another slide just to give an overview of all the potential complications that can happen with all weight loss surgeries, including cardiac problems, pneumonia, kidney problems, bleeding, all the other problems. What to expect after surgery? Postoperative care with a band. Typical stays overnight. You advance to regular diet from liquid diet in 2 weeks. Initially, there is no restriction with the band. We do the first band adjustment at 6 weeks after surgery to start making you feel full. Then we have follow up with your surgeon for band adjustments frequently every month to find the happy medium. We would like you to have feel full but not too tight that you cannot eat at all, but not too loose that you can eat a lot. So finding that happy medium takes a little adjustments. Usually 3 to 6 adjustments are needed before you find that happy medium. But once you find that happy medium, you follow up every 3 months. You take a multivitamin every day. With sleeve gastrectomy and gastric bypass, which are the more common operations that have been performed recently, the typical stay after laparoscopic surgery is 2 to 3 days. Liquid diet for 2 weeks, including protein shakes. Then we slowly advance diet over the next 4 weeks to a normal regular diet. You still eat 3 to 4 times a day and you still have restriction. Your follow up with surgeon at 2 weeks, 6 weeks, 3 months, 6 months, 1 year, and then yearly after. You have to take a multivitamin every day. Why do I emphasize that? Even after taking multivitamin every day, you can see this nutrition study that showed that after 3 months, at least 34% of people have one vitamin deficiency requiring additional supplementation. If you go to 1 year to 2 years, over 90%, at least all the people will have some kind of additional vitamin deficiency in spite of taking the multivitamin. And that's why we check your multivitamin levels 6 months and 1 year and yearly after to make sure your vitamin status are corrected. Here you can see the individual vitamin levels. Vitamin B12, iron, calcium, vitamin D, folic acid. People require additional supplementation, and that's why you need to have a visit with your primary care provider or the surgeon on a routine basis 6 months or so to check these vitamin levels and treat them before they get worse. Okay, now you heard about all the weight loss surgeries, what is obesity, what kind of weight loss surgeries. Then you have the question, what do I do next? Am I a candidate for surgery? Look at it. A definition by BMI. If your BMI is more than 40, you are a candidate for surgery. If your BMI is more than 35 and have other life-threatening comorbidities or obesity too with high risk, if you have diabetes mellitus, you have sleep apnea, if you have a history of cardiac problems, myocardial infarction in the past, you are a candidate for surgery. You also must have tried some supervised programs and failed. You are 18 to 55 years old. Of late, we have been doing for older people as well with a good life expectancy of 10 years or more. So we have gone up to the most have been up to 70 years of age. You should have a stable psychological profile, and you shouldn't have any abnormal eating behavior. What is the preparation? Okay, you decide that you are a candidate for weight loss surgery. What preparation is part of it? You visit with us first. You undergo a complete medical workup. You control your comorbidities, get your blood sugars under control, treat your sleep apnea, treat your hypertension. People who are smokers, we recommend you to stop smoking for at least 3 months prior to surgery, as this weight loss surgery is a major lifestyle change, and smoking is known to affect significantly complications around surgery and also after surgery. With all the connections in the stomach and the bowel, they are prone to make them worse. So we want you to stop smoking at least 3 months prior to surgery. We also want you to undergo 6 months of medical weight management, increase activity, get prepared for what changes you will notice, and lose weight close to surgery. We would like you to lose at least 5 to 10 pounds immediately 2 weeks prior to surgery. That way you have a decreased liver size, which helps with the surgery part. We also would like you to modify your eating behavior and get ready for the major changes that happen after surgery. So what are our program highlights? What do we do here differently? We offer all the 4 different options. There are very few people in the country who do the BPD, and we are one of the program which offers that surgery. We offer both laparoscopy and open approaches. We routinely do laparoscopy in more than 98% of the cases, and in people who had multiple surgeries in the past, then we may have to do open surgery. We can do that too. We individualize options. We have a multidisciplinary team approach. We have lifelong follow-up. We do support groups here, and we have intense level of care. Our multidisciplinary team consists of surgeons, medical physicians, nurses, there's a registered dietitian, program manager, we have an insurance specialist, physical therapist, and psychologist working together for your weight loss journey. What is the next step? You make an appointment to have a consultation with the surgeon, call our office at the number given here, check with your insurance company, call the member on your card and make sure bariatric surgery is a covered benefit. You may attend a live seminar on first Wednesday at 6 p.m. at Creighton University Medical Center or second Wednesday 6 p.m. at Emmanuel Medical Center. We also would recommend you to attend a support group at Emmanuel, at Creighton, and at Mercy. We have everywhere. Happens around 1 to 2 times a month. We would like you to meet other people who underwent surgery, so you know what to expect. Some people might talk about complications. Some people will talk about good things. We would like you to be well informed before taking a decision to undergo this major surgery. What are the frequently asked questions? Most common questions that I encounter and people asking is, what about excess skin after surgery? Most patients are able to tone their skin during rapid weight loss. If we don't, we can refer to a plastic surgeon for body contouring, which is around 2 years after surgery when the weight loss is the most. Is there a perfect operation for me? People ask this question commonly, like, what is the best operation for me? It depends on few things. How much weight you want to lose? If you are BMI 60 or BMI 40, how much weight you want to lose? What comorbidities you have? If you are diabetic, then gastric bypass is more better. BPD is the best but has higher risk. Gastric bypass is the next best thing. Sleeve gastrectomy also has good diabetes control, but less than the bypass. We look into all the comorbidities that you have, what best fits you, and how much risk you are willing to take. As I showed, the band has the least risk, BPD has the most risk. It's a risk that you need to decide how much weight you want to lose, how much risk you want to take for this surgery. And then you'll meet with one-on-one with our surgeons and discuss about individual surgeries, and that way we come into picture. Thank you for listening to the webinar. If you have any questions, please call us at the number that's written down and attend one of the live seminars that we do one-on-one basis. Thank you.